That was a great talk. I'd like to introduce Jim Hu, who will talk about comparative effectiveness research for robotic surgery and cancer treatment. Jim, and thank you for joining us.
My pleasure. Thank you. It's a pleasure and a privilege. Oftentimes difficult to follow David in these talks, but my charge today will be to discuss the scientific challenges of comparing robotic versus traditional oncologic surgical approaches. I'm going to focus more as well on radical prostatectomy because that, as you've seen from David's talk, has been the surgery with the longest follow-up and outcomes. And also, there's been mention already of these randomized controlled trials, but I'll just briefly mention some of the limitations and other considerations. And so Sheldon Greenfield had a nice review paper talking about the complexities of assessing comparative effectiveness research, particularly in the case of prostate cancer surgery. And he mentions here that there's 3 levels of variance that really need to be considered. First, the effectiveness of the procedure. Secondly, the quality of the operator. And thirdly, the quality of the device itself. And so I think that serves as a useful paradigm to kind of go through some of these complex issues here. So first, in terms of the effectiveness of the procedure, and again, this has come under recent fire here in the United States. I've had patients give me copies of a book called Invasion of the Prostate Snatchers, which I think is appropriate as we talk about over-treatment. And this New England Journal of Medicine paper, now with 18 years of follow-up, describes the benefits in the Scandinavian prostate cancer group of radical prostatectomy, regardless of the approach, versus watchful waiting. And from this slide here, we can see that there are benefits in overall survival from radical prostatectomy, particularly in younger men, those less than 65. Also, when you stratify by the DMECO and the NCCN risk group, low and intermediate disease. In addition, when one looks at cancer-specific survival, there's also benefits, particularly again in younger men, and in this case, intermediate risk disease. And then finally, when we look at distant metastasis as well as androgen deprivation therapy, which we know the literature evolving shows that there's detriments such as diabetes, coronary artery disease, and so forth, you see that there's benefits to radical prostatectomy across all subgroups for avoiding androgen deprivation therapy, as well as certain subgroups for avoiding distant metastasis. However, the trade-off, if you will, of surgery is oftentimes the functional outcome sequelae. In this case, Andrew Vickers did a very nice job looking at 11 surgeons at Memorial Sloan Kettering, and the surgeon heterogeneity, which again speaks to Greenfield's paradigm of operator experience in achieving preservation of erectile function as well as urinary function at 12 months. And so just going through the example here for erectile dysfunction, one can see that there's a large range here between 50% recovery of erectile function to less than 10% here at 12 months after you control for patient characteristics. And so when we look more at the quality of the operator, or specifically at learning curves for robotic-assisted radical prostatectomy, there's been several single institution series that have mentioned that the threshold for decreasing complications is about 150 cases to achieve a reduction in positive margins less than 10%. It was 1,600 cases, plateauing of operative time 750 cases, preservation of sexual function 1,400 cases. And so there's a great deal of experience here that needs to be attained in order to achieve some of these landmarks. However, one must keep in mind that data from the American Board of Urology indicates that on average, urologists in the community perform less than 10 operations per year, major operations including radical prostatectomies. And so I won't belabor the advantages here. I think suffice it to say, David's video was very instructive. If you can think of the prostate cancer surgery as particularly the nerve sparing as peeling an orange deep within the pelvis, again, this wristed motion of the robot comes in handy as well as for reconstructive purposes. When we talk about the quality of the device, this was a review of the MOD database that the FDA keeps, and one can see that the number of reports relative to the number of cases is relatively low, although again there may be underreporting of some of these complications. And then there have been several versions now. Again, the device manufacturer is a robot, but we can see here as we went from the original Da Vinci to the second generation, if you will, there were mostly declines in the number of malfunctions. Now, having said that, one has to also consider the fact that robotic-assisted surgery is really a misnomer. It's really computer-assisted surgery in that the robot is not autonomous. And when you look at things like injury and death, some of the things that David talked about in terms of longer operative times contributing to rhabdomyolysis or relative inexperience with recognizing laparoscopic anatomy here, I think is the largest contributor to those two suboptimal outcomes. When we talk about population-based comparative effectiveness studies, the JAMA paper that we published in 2009 looked in SEER Medicare at comparing open to robotic-assisted surgery. And again, mirroring some of the findings from the Michigan Urologic Surgery Collaborative, there was a shorter length of stay of 2 versus 3 days. There was also a lower heterologous blood transfusion rate. And again, here, one can see that certain complications were, or most complications rather, were fewer, particularly stricture or scar tissue formation. Again, when you think about that video that David showed, you can see that with the robot, it was much easier to do the anastomosis. With open surgery, oftentimes, you don't even see the bladder coming together with the urethra. You're just tying the knot down by feel, and hence, I think that's why you have the lower stricture rate formation. Looking more closely at the genitourinary complication now, that I think has to do with how that complication is coded, and that stems from that Begg-Scardino paper from the New England Journal of Medicine. And we looked again at the 100% sample, so more statistical power over a similar period of time. And here you can see that cystography utilization, which is a component of genitourinary complications, was much higher in a minimally invasive or robotic approach compared to RRP or open. And that just speaks to, I think, the relative getting cystograms or radiographic images of the reconstruction to make sure that that's come together more nicely, because robotic-assisted surgery has been associated with earlier catheter removal. Now, of note here, and it has been touched upon by the previous speakers, with this type of statistical power, one can also look at the perioperative morbidity. And here, one can see that in terms of some of the complications for open versus robotic, there was also a lower risk of 30-day mortality, 0.2% versus 0.6%. So a very uncommon event, but again, speaking to, I think, the lower blood loss associated with robotic surgery. Now, this was really what made the headlines, in that robotic surgery was associated with more diagnoses of erectile dysfunction as well as incontinence. And one has to really think about patient-reported outcomes versus claims-based outcomes. And I think, again, a secondary analysis that we did hints at potential reasons behind this, as well as the direct-to-consumer advertising that David mentioned earlier, that would attract people, therefore having higher expectations of this relatively new technology. However, it's common practice after radical prostatectomy, regardless of the approach, and this is largely patient-driven by, I think, what I would characterize as soft data, of doing potency rehabilitation with sildenafil and its similar medications relatively early in the postoperative period. Now, in order to do that, however, one has to see the urologist, get a diagnosis code of erectile dysfunction in order to get that therapy, which in and of itself can cost $240 a month, taking medication on a daily basis and so forth. And so here again, one can see that consistently during the recovery period, men undergoing minimally invasive or largely robotic surgeries were more likely to seek potency rehabilitation, get this prescription for sildenafil and its other variants postoperatively. And so again, I think that contributes to that higher diagnosis rate of erectile dysfunction. Now, more recently, coming from Sweden, there was a comparison, a prospective, non-randomized comparison of centers that did robotic versus open surgery. And here you can see that in this very large population-based study, looking at a wide variation of definitions for erectile dysfunction, the robotic surgery odds ratio was more favorable in terms of ED after surgery. And so we're starting to see, I think, some shift in terms of the robotic approach being more favorable in terms of functional outcomes. And this was recently presented at our American Urologic Association just in May from David Penson, his PCOS, prostate cancer outcome study, as well as his CSER study, which involve a lot of SEER regions and sending surveys to patients using validated quality of life instruments, in this case the Expanded Prostate Cancer Index. And this is the difference in the score between open versus robotic surgery at 6 months as well as at 12 months. And John Way and Marty Sanda, who developed this instrument, looked at the minimal difference that led to statistically, or rather a clinically significant benefit and that was around 7 points. And so here again, you can see that for the robotic versus the open approach, that the difference in that 0 to 100 score for the expanded prostate cancer index in the sexual function domain was clearly better for the robotic versus the open approach. And so I think we can see that as surgeons progress beyond the learning curve, there are some benefits now to the robotic approach in terms of functional outcomes. However, in that study, there was no difference in urinary function recovery. Now, speaking about the question of cancer control that was touched upon earlier for radical prostatectomy, we again looked at the SEER database, which captures positive surgical margins, and we found that across all subgroups here, with the exception of low-risk disease, and we don't have T3B or more aggressive cancers that invade the seminal vesicle, but we consistently find that the positive surgical margin rate is lower for robotic versus open surgery. Here, overall, one can see 13.6% versus 18.3%. So speaking somewhat to the benefit in terms of cancer control for robotic versus open surgery, potentially due to better visualization as well as the lower blood loss. Now, I'm going to present some unpublished data now that addresses this question a little further about cancer control. But first, again, looking at the latest release of the SEER Medicare database, we can see that in contrast to states such as Michigan, where there's much higher penetration of robotic surgery, we found that in the SEER regions nationwide, it's about 75% uptake. And then when we look at the freedom from additional treatment here, looking at additional radiation therapy as well as androgen deprivation therapy, we actually find that there's less utilization of those additional therapies with the median follow-up of 7 years for robotic versus open surgery. Now, there's an absence in this database of looking at biochemical recurrence. We don't have any PSA information, but certainly the practice pattern is such that with a rising PSA, there's randomized controlled trials that show the benefit of salvage radiation therapy. Now, when we looked at the overall survival here, again, the median of 7 years after surgery, surprisingly, we find that the overall survival in this Medicare population, again, was better for robotic versus open surgery. Important to realize that we can't control for variables that aren't there, such as body mass index, use of alcohol, tobacco, exercise, other lifestyle factors there. So again, that direct-to-consumer advertising may play a role here. However, looking at cancer-specific mortality, and again, when you think back to the study from Scandinavia that I showed you earlier at 18 years, some of these findings were significantly different. However, at a follow-up of 7 years, we don't see any mortality difference. And you can see here on the probability on the Y scale here that, again, most people are dying from prostate cancer at 7 years of follow-up.
I want to go back to that. So how many patients are listed? 100 in each?
Yes, exactly. You can. Right. No, that was not significant. And so the cost issue has been addressed earlier. Suffice it to say that for the robotic-assisted approach versus the open approach, you're looking at least at a cost difference of $2,400. Some of this also relates to how often the robot is used. You saw the breakdown of the fixed capital cost, the 10% maintenance cost, and so forth. And again, David's spoken about this previously, so I'm not going to belabor this point. I'll just mention again, you can see some of the differences between a randomized controlled trial conducted at a tertiary referral center such as Memorial Sloan Kettering, and nationwide inpatient sample data here that we published looking at radical cystectomy. The uptake in 2009 was about 10% of all radical prostatectomies were done robotically. Here again, we see a benefit in terms of, at least in community settings across the United States, lower inpatient morbidity over the robotic approach, 0 versus 2.5%. There were also fewer complications here that reached statistical significance. However, the cost difference here was about $4,000. Again, this was mentioned earlier, the randomized controlled trial. I'll just mention briefly that I think the most critical thing is that this is the second version published in European Urology, which gives, I think, finer details. And when you look at this, when you look at this table, you can see that the differences for a benefit in terms of the robot was really in lower blood loss. There were no differences in complications, which strikes a contrast to the population-based study. And in terms of costs, again, depending on the type of diversion, whether they did an incontinent diversion to the skin versus a neobladder or replaced the bladder with intestines, the cost difference was either $4,000 or almost $2,000. And so there was a nice editorial to this publication that Indy Gill, who's a leading minimally invasive surgeon in our field and chairman at USC, He questioned the experience, the relative experience of the robotic surgeons at Memorial Sloan Kettering. And clearly they've published a lot. The earlier slide I showed you was in prostate cancer, but there's been a lot of publications as well in bladder cancer. So again, I think the surgeon experience or the operator quality here is a little unclear. And while there was a significant difference in blood loss, there was no mention of any differences in transfusion rates from that study. I'm not going to belabor the ROLARR study, which both prior speakers in this session have mentioned. I would just highlight the fact, again, looking at surgeon experience, the laparoscopic surgeons in this study had relatively 3.6 times more experience with the laparoscopic approach compared to their robotic surgeon colleagues. And so again, going back to Sheldon Greenfield's paradigm, when you think about these comparative effectiveness studies, one must consider a relative difference in the experience of the surgeon. And so in conclusion, I would say that comparisons of surgical devices and techniques must be made beyond the surgeon training curves. We're seeing emerging data now, both patient-reported outcomes from Sweden as well as here in the United States, that there's sexual function benefits for robotic versus open radical prostatectomy. There's also cancer control benefits as we look on a population-based level in terms of positive surgical margins, as well as less use of additional cancer therapies up to 7 years after treatment. And David mentioned earlier there's a Australian randomized controlled trial for radical prostatectomy that just started in 2011, so we'll see what those results show. But again, in the United States, as Dr. Weill said earlier, for laparoscopy and also for robotics, we can see that the horse is out of the barn clearly for prostate, and I think we need to be thoughtful about, as there's greater utilization of this technology for other cancers and disease processes, how we can better unroll this in a more thoughtful fashion. Thanks for your attention.